Good evening, everyone. Here I am, Radha Boss. Again, we are live. I am live from Dubai, and Professor Rui Ribeiro from Portugal. It is great honor to interview such a prestigious figure. My viewers, you know better than me. Professor is an international figure, and his contribution for promotion of bariatric surgery, no doubt, in any international conference, any international symposium. So professor is there, and also always his passion is sharing knowledge. And in my opinion, that we have started this interview series, one of our target is sharing knowledge. And definitely tonight will be one of the best interview. And in my, please, my humble request to all of you, if you have any question, you can ask in comments or directly from myself, and I will then convey your message to Professor. Sir, I will not take your time. Please, over to you.
Thank you so much, Imran. It's a great honor to be here and to share the screen with you and to be able to help to teach people about this science that we are practicing, the bariatric and metabolic surgery, which is really a marvelous field where we get very good outcomes from our patients, and it's really, well, awesome. So I am at your disposal for any kind of question and to do my best.
Sir, so much thanks, as you know, so because you are also faculty member of global laparoscopy and robotics, and really you are always supportive and encouraging. So we have series of questions and same questions, so I will repeat. I have divided these questions in 3 groups. So this patient selection or pre-operative and some technical points. Then at the end, we will talk about some post-op or follow-up of our patients, because today our interview is about Roux-en-Y gastric bypass. So I will repeat the same questions, and after 6 months, we will have some obsession. Sir, we are interested, personally, I know, but my viewers also are interested to know about you, your brief introduction, your journey of bariatric surgery, and especially journey of Roux-en-Y gastric bypass.
Sure. Well, I am a general surgeon. In Portugal, we don't have any kind of digestive surgery or something like that. We are all general surgery. And in 2001, I decided to approach the bariatric surgery. So I began to practice this art with the gastric bands. At that time, we have put a lot of bands since 2001. But very quickly, I understood that band would not be the future, because people could lose weight, but not enough weight. Sometimes they were still getting fat. So I decided to begin training with gastric bypass. It was tough at that time because there were not so many people teaching it. And even in Portugal, nobody was doing that. So I need to go to Sweden and to Spain and to Brazil to learn a bit. And in 2002, I was able to perform my first Roux-en-Y gastric bypass, a revisional one, very tough task. It was a band with a complete obstruction. I took 7 hours to perform my first bypass in that condition, very tough. But very soon, 2 months later, in 2002, I've done my primary one, and it was quite different, 2 hours, much more comfortable. So, and I began a long series of Roux-en-Y gastric bypass along the years, and it was clearly my mainstream operations. But anyway, I was searching for better solutions, and I remember I've done my first sleeve in 2006, very early in the international panorama. And my goal was to get the level to be able to perform which I got in 2008. I was performing duodenal switch and also Scopinaro operation. And up to 2010, I was performing, but because of the nutritional issues that everybody knows, I decided to quit and to search for a better operation. And in that time, also I was having some troubles with the Roux-en-Y gastric bypass, mainly hypoglycemia cases that were difficult to solve. And people were not living very well, and I didn't have any good solution for those patients. I don't have it still nowadays. It's a difficult situation. So, and because mainly of hypoglycemia, I began to ask people that were performing OAGB. I'm referring to Miguel Angel Carbajo, Manuel Garcia, Spanish guys that were my friends, and they are very honest. I had a big confidence about their counseling. They thought, no, it's a good operation. There is no hypoglycemia. I talk also, I had a conversation also with Rutledge and Jack Impen, Rudolf Weiner and Roberto Taquino mainly. At that time, I was part of the faculty of the European Training Center of Surgery from Covidien in Elancourt, and we have spent a lot of time together, and he talked a lot. It was a kind of master for me about that. And I decided to change for the concept of OAGB. That was not very, I was not very available for that because I was thinking, oh, one lesson of osmosis that is 10 minutes, not so important. But finally, I understood that it was a better operation, doesn't mean that Roux-en-Y is bad. It's not, it's a good operation, but there are less problems with OAGB in my view. Anyway, in 2008, I began also with SEALS approach, single port, and I performed a lot of sleeves and even OAGBs by SEALS. That was my track. And in 2010, I began OAGB, and the main issue I faced, first of all, was bioreflux. I had 4% of the cases of bioreflux that I converted to the so-called Roux-en-Y diversion. And I noticed that those patients were, after that conversion, very, very good, very, very well, without symptoms and keeping their weight low. So I began to think, wow, why not to apply this formula as a primary surgery? And that in 2013, I began to perform the so-called diverted OAGB, or long pouch gastric bypass, that I published in 2020, a series of 400 cases and I'm still doing mainly in cases with reflux. Since then, the number of Roux-en-Y decreased, but LPGB or diverted OAGB is still a Roux-en-Y. So, and I use it in cases of reflux, and I only performed a short pouch, the classical Roux-en-Y, in cases of severe esophagitis or Barrett's esophagus. In that case, I really perform a short pouch. But all the other ones, I do prefer a long pouch because it's more physiological, in my view. What else? Yeah, and I'm doing that kind of, and nowadays I'm working also the concept of transit by partition that I like a lot.
Sir, we will go ahead, definite, and it's a great introduction. And now I am talking with someone who has experience of Roux-en-Y gastric bypass about 2 decades. Definitely, yeah. Tonight it will be a great session, and we will talk different questions we have. So regarding, sir, pre-op, because some things that is in data and guideline that is different, and yes, we all are following data, following these guidelines, but also you have your own experience. So what is my expectation and by viewers sharing of your personal knowledge, because they think that you're sharing now, we are at least 5 years ahead to book. So that things that will be in the book and literature will be maybe after 2 years, 3 years, 4 years. Just now we have someone who has more than 2 decades experience of Roux-en-Y, and just we are talking with him. Sir, but according to your protocol, what is the absolute and relative contraindication of Roux-en-Y gastric bypass?
Well, there are not really indications for Roux-en-Y gastric bypass, as we cannot. The big problems are the weight regain and the hypoglycemia, in my view. So I suppose that any patient can receive a Roux-en-Y gastric bypass, but we know that are weaker candidates for mainly people with diabetes. They are probably more prone to have hypoglycemia, maybe, and people with superior obesity, the more severe obese people, we know that Roux-en-Y is not so strong, and the weight loss will not be satisfactory in most of the cases. So in those cases, I try to stay away from Roux-en-Y gastric bypass. Although I didn't say it before, but even what I definitely changed was to increase the biliopancreatic limb, even in the classical Roux-en-Y gastric bypass, in order to get more weight loss. In that sense, Roux-en-Y can be a good operation also, and I'm doing it, as I said before, even if, but with differences, with the long biliopancreatic limb and with the long pouch. Contraindications are also, of course, the regular one from bariatric surgery, addictions, respiratory problems, glaucoma, etc. But there is one that is very important, that is the smokers.
Yeah.
Smokers and alcoholic habits are, for me, an absolute contraindication for Roux-en-Y or any kind of gastric bypass because of the risk of marginal ulcer.
Sir, excellent, excellent, sir. Sir, you have highlighted 2 or 3 times mentioned about hypoglycemia. So you mean this is due to dumping or this is due to neuroblastosis?
Well, nasoplasmosis has never been documented in humans, only in rats, okay? We can imagine that there is an increase of the beta cells, but we don't know really if that is the figure or if there is only a bigger sensitivity, and we know that it happens to insulin, okay? So I suppose they are both realities, and but of course the insulin production will be more efficient, and that's what interests us. But sometimes maybe the problem is the trigger of the insulin production, because if the sugar absorption is too fast, of course, the pancreas is able to produce a big shot, and that's what will produce the hypoglycemia. So, but I'm not sure that nasoplasmosis exists. Of course, the cells will produce very well the insulin, and the sensitivity is very high.
Sir, in case of any liver issue like cirrhosis, so now, yes, that is the documented cirrhosis before surgery. Again, you will go for Roux-en-Y gastric bypass or no?
No, you are right. That's another contraindication. Of course, any kind of cirrhosis or hepatic insufficiency, child B or C, I don't like to perform bypasses. I go for other operations.
We will go ahead for this.
That's true.
Thank
really.
you. Sir, regarding age limit, according to your experience, so not according, yes, I know you are a scholar, you are someone who also, you are one of the person said that we see guidelines from yourself. So have you any age limit for Roux-en-Y gastric bypass in adolescents or in older age, like older than 65, 70? Have you any criteria?
Not really. In the adolescence, I would say that I've tried along this 21 years. I began with bands, and the bands failed, as usual in adults. I went for sleeve, and I have also failed with sleeves, even in adolescence. Some people have got very good for the rest of their life, but some they become fat again. And I tried also Roux-en-Y gastric bypass, and of course the outcomes are better. So I suppose it's a good solution. I'm not afraid of what people say, what's going to happen with that anastomosis with a long time of gastric bypass. I suppose, or about nutritional deficits. I suppose that if the patient is able to understand what he's doing, the patient or his parents, of course, and it's coming to the follow-up, and we know that there is always a bowel adaptation, and the absorption will be better year after year. And because of that, I do bypasses in adolescents. Nowadays, sometimes Roux-en-Y, there is reflex, sometimes OHGB because it's simple and a little bit more efficient, maybe.
Yeah.
About old people or older people, it's a bit different because we know that the so-called bowel adaptation about absorption is not so efficient. So, and in those cases, I try to avoid gastric bypass because sometimes we're going to have to reverse. Reverse to the normal anatomy, two bypasses in older people because and they had big, longer common channels. They could absorb well, but indeed they were in malnutrition, and I had to convert to the normal anatomy. So I don't recommend it old people.
Sir, this is the why I have started this interview series. You have highlighted a point that in older age, adaptation of small bowel is not like a young people, because in young people, yes, we see hyperboles and also this. Then after some time, So the absorption of that jejunum is increased, but definite in older people that are at risk, and especially, sir, if you want to so add the comment about menopause. So someone in menopause and with the osteoporosis, symptomatic osteoporosis. So are you routinely rule out osteoporosis and this bone densitometry, and then you change your opinion or no? What is your protocol?
My protocol is usually you don't perform the orthodensitometry since the beginning, unless there is already pain or history of such a disease. But usually you operate young people, they are not thinking about that. And there is another issue, it's an expensive examination. I prefer to get in the very good supplementation, and I had in my appointments this afternoon, this evening, at least 6 patients, and all they are taking calcium and vitamin D in enough amounts to have normal values in my lab's control. So that's more important. Of course, we know that with menopause, every woman will have an increase in the osteoporotic disease, and mainly also because they are not active, physically active. That's very important. And something that I try to teach to my patients, that the exercising is very important, not for lose weight, but mainly to keep an healthy muscle that will spend energy during the night and keep the weight low, and will keep the bone healthy also, because the best stimulus for the calcium entrance in the bone is the exercises and the strength of the tendons on the bones. So that's very important, and I try to push every body, me and my team, of course, to exercise. But to say that I'm doing osteodensitometry as a rule, no. Only when patients have complaints, and usually in older patients.
Sir, if someone documented now osteoporosis, this is my question, and also this osteodensitometry confirmed, yes, patient is suffering with the osteoporosis, and patient is morbid obese, no more than BMI more than 50, age is about 60. So are you again will go for Roux-en-Y or no? You will prefer in such a situation sleeve gastrectomy?
In that situation, I can prefer sleeve gastrectomy, but because honestly, I'm not a sleeve fan because of the high percentage of cases of weight regain. I have nowadays 4 or 5 cases waiting for conversion from sleeve to other operations because of weight regain, and because I consider a lot reflux a big problem. So, and we know that there is a high percentage of de novo reflexes and aggravated reflexes after sleep. So I do just a few sleeps, but for sure, in older people, it's a good solution, and I do it sometimes. But nowadays, I have done mostly the concept of the transit bipartition that we can have the benefits of a sleeve and the benefits of an early ileal stimulation with all the metabolic benefits, and there are still some absorption of calcium and other nutrients in the regular, in the mixed loop, if you can say it, and it can save the patient from osteoporosis a bit.
Thank you, sir. Sir, next question, that is also a common question in different international conferences. So what's your protocol for pre-op endoscopy or H. pylori eradication?
That is a very sensitive question for me, because I do all my life, in 21 years, I just operate one patient without an endoscopy. One patient that I don't know why, I can't remember, I couldn't convince him to perform an endoscopy, but he has done an X-ray. But every patient has to perform an endoscopy. Why? Helicobacter is another issue, but why? Because we can have esophagitis, and it's very important to decide what operation we're going to do. We can have polyposis, and that can be risky to leave an hidden, an excluded stomach with important polyposis. We can have DLFA cases that may be in contraindication, varices, esophageal varices. So many things that can contraindicate to an operation or push to another kind of operation. So I suppose endoscopy is mandatory in all the patients, and I've done it all my life.
Yeah, please.
About Helicobacter, we test every patient also. Double test, we performed, we asked for the antibodies, IgM, in blood, and we in the endoscopy we ask for biopsies with Helicobacter search. So we have a way of controlling the situation, and usually it's okay. If one is positive, the other one is positive as well. But sometimes, and I found the case last week, I suppose, I had a negative biopsy with a positive antibody. So in the doubt, we treat also those patients. And very important, we repeat the test every year in the follow-up. After 1 year, 2 years, 3 years, we go for the test in the bone, in the blood, and if positive, we replicate again.
Sir, this is important, very important that you have highlighted. So what's my question? Now your surgery number is in tetra, no doubt in thousands of cases you did bariatric surgeries. What is my question? If you have any data about percentage of your patients that you have changed your decision after endoscopy. You were planned, just you have planned, yes, I will go for one by gastric bypass. You did endoscopy. Oh no, this is not good case for this according to this endoscopy. Or you have planned for OAGB. When you did endoscopy, oh no, this is not good case. And you have changed your that schedule planning or your protocol. How much cases you think? Which percentage?
I don't have a clear number for you, but I would say at least between 10 and 20% it happens. Mainly because I told you, reflux is a very important thing in my opinion, because I used to say that gastroesophageal reflux is the best, the black beast of bariatric surgery. And it's very important indeed, because we know that a patient with reflux can be a disaster. It can drive him to eat more, and he will have also complaints and getting weight again. So, and it's a suffering, and there is risk of esophageal cancer because of the chronic esophagitis and Barrett's and so on. So we need to respect that. And of course, I've told you before, my main operation nowadays is OAGB, but I suppose there are a little bit less, but almost as many cases I'm performing the Roux-en-Y gastric bypass because of reflux. Only in esophagitis grade A, I don't put Roux-en-Y diversion. But even in esophagitis grade B, if I have an hernia of 2-3 centimeters, some people say that I don't touch it. I touch it, I close the crus, and I make a diversion. And if, of course, there is an esophagitis CD or an Barrett's, always. It's very important. And even, for instance, people with gastric bands, the so-called failed bands, I know that this is not very commentable nowadays to say failed, but people with bands that have regained weight or with sleeve that have gained weight, some people in those cases, maybe you can perform an OAGB as a salvage operation. I don't do it. Why? Because when I began to do that since 2010, I found many cases that OAGB had a bigger reflux, an important reflux after those situations, after restrictive surgery, after band. My interpretation is that the band or the sleeve destroys somehow the transition, and those patients, they resist badly to the reflux. And of course, in OAGB, we have bile in the stomach, not bile, enteric continence with some bile, diluted bile, but even though bile. And I don't have any way to have bile in the esophagus of my patients. So in those patients, after sleeve or after band, since many years ago, I convert always to long pouch gastric bypass, which is a Roux-en-Y.
Sir, thank you, sir. Sir, regarding so definite bile in stomach is not an issue because routinely also we see the bile in stomach, bile in esophagus, an issue that you have highlighted. So, sir, my question regarding this same again, endoscopy, in these 2 decades that you are doing endoscopy, have you remember any patient that was, so there was this is incidental finding of malignancy? Have you find, or you remember any case?
No, no, I don't know why, but maybe because our policy in the preoperative setup, I remember one patient that we found a malignancy, and of course he was not operated.
Yeah.
I had maybe, I suppose, 3 cases that we found significant GIS,
Yeah.
gastrointestinal stromal
Yeah.
tumors that we moved before the operation. We moved and made the bariatric surgery later. And I had one malignancy after one bypass also.
Yeah.
But in the extruded stomach, not in the
Remnant. Yeah, it was in remnant. Sir, another question. Yeah, regarding this H. pylori that you have highlighted, routinely you follow all of, as I understand, all of your patients after surgery, 1 year, 2 year, 3 year, H. pylori. So how many patients become positive? All of them were previously also positive, or no? Someone they were negative. Have you any data, such a data?
I never studied that, but I would say that most of the patients they are still negative after 1, 2, 3, 4 years. I suppose maybe 1/5 of the patients can get positive again, and we do treat all the patients. But let's consider that I'm not following 100% of my patients. Not me, not no one. No one is able to do that. But I suppose that they have more than 50% of the patients controlled, but we don't know what is happening with the other half of our population of operated people.
Thank you, sir. Sir, now we will talk about some technical points in Roux-en-Y gastric bypass. So regarding definite, any surgeon, so they have some evolution in the technique till in lab chole, in all types of surgeries, they have some technical evolution, and definite this during this bariatric surgery journey and 2 decades, definitely you have changed your protocol already. You have mentioned now this pouch is longer than previous Roux-en-Y gastric bypass. Yep. Can you also highlight other like your BP limb and also the size of gastrojejunostomy, the length of BP limb? You have touched this. Yes, now the BP limb is longer than previous for more weight loss. Can you highlight your technical points that you have evaluated?
Sure. When I learned the Roux-en-Y gastric bypass with Hans Lönnrot, he is still alive, an important Swedish surgeon working in Gothenburg. I learned with him mostly, and he was performing a short pouch with a 12 millimeters gastrojejunostomy, very narrow, in order to allow the passage of solid food, but in small amounts, very well matched. I learned also following that with Albino Ramos, that was doing almost the same because it was very similar, but short pouch, very well calibrated anastomosis. Of course, I had several cases of stenosis that I was dilating. Okay, dilation can solve most of the cases, but I have a case where they blow up the anastomosis in the dilation, and I have to reoperate in poor conditions the patients because of dilation. Well, later on, and I kept doing that kind of surgery up to 2010, but after the concept of the OGB, first of all, I decided to perform longer biliopancreatic limbs because I understood that was the key of the success. That was where the money is, where some people could say. Because honestly, I believe that a longer biliopancreatic limb is the main issue, is the main factor to have a good weight loss and a good metabolic effect. Maybe because of the bile acids absorption, maybe because of the microbiota changes, or altogether, maybe because of the glucidic consumption of the bowel itself. So, but long biliopancreatic limb is important in order to have a good weight loss. But some people call it we're going to malabsorption. No, those are different things. That's a concept. I'll come back to the technical issue shortly. My concept is one thing is malabsorption. When you put food ahead, we need to have enough bowel to have a good absorption of protein and fat and so on. But we need also to go further to have a very good metabolic effect. And the art, the key is to play with those two concepts and get safe measurements. So because of that, my main change was to measure all the bowel in all kind of surgeries of bypass. OHB and Roux-en-Y, I measured all the bowel all the times. That's, of course, it can be risky, but with training is not so difficult. And of course, I had a couple of cases of perforation that I could treat easily with no death. So, but I measured also, and I could find bowels as short as 4 meters and as long as 12 meters. So that's why making a classic Roux-en-Y cannot work in all the patients. If you put 80 centimeters of biliopancreatic limbs in 12 meters, it's nothing. So we need to adapt. And I'm tailoring the biliopancreatic limb, that's the other main change, following the rules of OHGD, because I learned mainly with Carbajo that you know that is adapting a percentage of bowel for the biliopancreatic limb. So we try to measure the bowel and put enough bowel to assure a good absorption of nutrients, but putting the food far enough for a good metabolic effect. It's more or less this. In a Roux-en-Y, my rule is to have at least 3 meters of common limb for absorption. With 3 meters, we are quite safe, okay? And I'm saying these things 10 years ago, not, some people are repeating that, but it's enough. Some people consider 250, but I suppose 3 meters is more safe. There is another rule, 50% of the total bowel length is also safe, but at least at that point we can go. But if you have a mega obese, for instance, we need a big power, so we need to go further away. And sometimes I use 50% of the total bowel length for biliopancreatic limb. And look, another issue. In order to avoid reflux, even in Roux-en-Y, I perform always 1 meter of alimentary limb. So alimentary limb is always 1 meter. Common limb must be longer than 3 meters, and I need to have as long as possible biliopancreatic limb. In a patient with in a BMI of 40, not so metabolic, I can use 40% of biliopancreatic limb, 40% of the total bowel length. In a super obese 50, if patient is diabetic, I try to put some more 5%. And we have that kind of rules that came from the OHGB practice also. Sorry, it was a little bit confusing. About anastomosis, I changed completely. Instead of having a narrow anastomosis, provoking vomiting and dilation of the pouch because of high pressure, I decided to do it longer and with a large anastomosis, 3 centimeters at least, that will produce no vomiting. My patients usually don't have vomits. It's not frequent. And because there is no high pressure into the pouch will not dilate so much as a short pouch with a narrow anastomosis. So, and that's the concept that came from also Sergio Santoro. Now I do prefer operations without huge restriction. So we don't have to make torture. People should avoid eating because of physiological restriction that is connected to the incretins produced in the ileum, and not because of a narrow ring or a band or a scar that doesn't allow. That's torture. Okay. And second concept, don't have or try to not having excluded segments of the bowel, but that's the concept of bowel bipartition.
Sir, regarding this length of, this is excellent information because you have mentioned, so measure whole small bowel in all your patients. Just imagine a patient with BMI 55, 60, morbid obese, or 50 years old, 45, 50 years old, and the whole bowel length is 10 meter. In such a case, have you any experience, or this is your routinely practice? So in such a case where 10 meter, we have small bowel length, and now BP limb will be 5 meter, 1 meter will be rule limb, and 4 meter will be a common channel. And there is and now you're following this because you have mentioned now about 1 decade, 10 years, more than 10 years. This is your protocol, and you're following your patients, and they are good.
Yep, I would do so.
In primary surgery, this is initial.
5 meters below pancreatic and 1 meter and 4 for absorption. Okay, that would be good. Or maybe it depends of the patient. 55. 55 is good. But if the patient would be 65, I would do it differently with more 50 or 1 more meter for absorption. If it is an infection, I can go after. The more aggressive case I've done, it was a boy. He was about 28, 29 years old. He was 290 kilos, BMI of 99. Ooh. And I performed the OAGB with, I suppose, 6 meters of biliopancreatic.
Oh my God.
So very aggressive. And he came down to 140, but never more than that.
Till this time, because in such a age, again, that you have mentioned so adaptation of small bowel, that is really amazing. And also this is from nature. Then absorption start. Still, sir, you can't believe now I have started OAGP since 2013, and now I am facing weight regain. So patient, sure. I did BP limb was 250, 220, 230. Now really, now just 2 days ago, a patient came with the weight regain, and then I reviewed the file. Oh my God, this BP limb was 220. And also BMI was not about 40 plus, not it was BMI like huge BMI and morbid obese. So yes, I agree with you, but the patient is young, so we must think about this. And these things we will talk about this. I think we cannot standardize. It depends on the different ethnicities and food and also this dietary protocols.
We need to tailor to each patient, and that's very important to what you commented, because we need to understand and we need to explain to our patients that this is a chronic evolutive disease.
Yeah.
Now we are doing a treatment measurement, a treatment step, but we know that the nature will always try to fix what we have done wrong to the metabolism, and the bowel will adapt and absorb more. The incretin will be less important. Ghrelin, that as is appear after a sleeve, will be produced again in the colon, and the anger is coming again because ghrelin is also again increasing, and and the metabolism also increased a lot after the operation, but with time it will decrease again because people don't move, don't exercise. That's a big issue. Maybe in the future, the main issue for the bariatric patients in generality is the sarcopenia. No? Well, the short amount of muscle.
Sir, always that you highlighted again. Excellent point. So what I talk always with my patients, my role is 30%. And after surgery, patient role is 70%. So changing the healthy lifestyle, that is the key for the maintenance of weight loss. If you will not change, definitely you will face such a situation. Sir, another nightmare for surgeon and also for the patient after Roux-en-Y gastric bypass is internal hernia. Really, it is again a nightmare, and definitely maybe you have also faced such a situation. So for prevention of such a situation, so what is the guidelines? Closing the defects, Peterson and JJ defect. So what is your protocol, and have you faced any such a disaster?
Nowadays, and I would say since 4 years ago, I'm closing both the spaces, the intermesenteric space and the Peterson space in every patient in Roux-en-Y, and even the Peterson space in OAGB. But let me tell my evolution. In the beginning, I was not closing, nothing. I suppose in 2004, I was presenting a video in a congress, and Jack Impens was in the public, and someone asked his opinion and said, well, it's all done, but I would close the space. Okay, I begin to close the intermagnetic space, so at that time. Later on, I confirmed with Kelvin Eger that Kelvin Eger had a big, in the beginning was not closing, and he had a high number of internal hernia, and when he began to close it, the number reduced a lot, okay? So, and I had cases of internal hernia, not so much, but at least a dozen of cases I had to deal with. But 5 years ago, even in Rouen, we began to speak about to close the Peterson space, and I began to do also. And honestly, nowadays I'm not having. I suppose that since 5 years I didn't add any case of internal hernia because we are closing the spaces. Probably, maybe one case can go to another surgeon, maybe, but the best of my knowledge is not happening, except one case that was an exception. It was a patient with a diverted OHB, a Rouen Y, that I have operated primarily with a big hiatal hernia, a big one that I reduced. I treated hernia, I performed the bypass, the Rouen Y gastric bypass. The patient was good for many, many years. I suppose it was before 2010 that he was operated, or 2010 maybe. And last year, he came up to us with a pancreatic cancer. Yeah. Okay. It was diagnosed, he was performing chemoradiotherapy. He was very, very thin. And at that time, he had but it was very, very thin. And we know that when people get thinner is when the hernias are more frequent.
Yeah, sure, sir. Sir, thank you, sir. Thank you. So now we will talk about some post-op for Rouen Y gastric bypass due to shortage of time. We will go ahead. Sir, regarding your protocol, post-op endoscopic surveillance, what is your protocol? You have mentioned about H. pylori, but about endoscopic surveillance.
My protocol is mainly because of I was pushed far away because of the criticism to the OHB. And because of that, I suppose more or less 5 years ago, I decided to change our protocol and to perform endoscopies after 1 year, 3 and 5 years. And I'm doing so. So all my OHBs, and because of that, all my sleeves, and because of that, all my Rouen Y gastric bypass, we are doing the same for everybody. And what can we conclude about that? It's really with the OHB, there are some bile in the stomach, but that's not a big issue. They are not complaining of nothing. Certain patients, about less than 5%, they can have bile in the esophagus, and with those ones, we divert to Rouen Y gastric bypass. With sleeve, we have a lot of esophagitis, and also some cases of bile in the esophagus that we propose to convert to Rouen Y. And even in Rouen Y, I have 2 patients with bile in the esophagus after many years. So we know that it can happen. So I suppose it's important to check with endoscopy. It's not so difficult, it's not dangerous for the patient, it's a safe procedure, and it's not very expensive here. So we are doing that, and even today I saw, I suppose, 3 or 4 endoscopies, and everything was perfect in the patients of today, of course. But sometimes we have bad news from endoscopy.
Sir, which percentage of your patients are suffering with marginal ulcer? Have you any data?
Yes, 2%. Yes, though they have studied because why? Well, the opposite. First, I studied the percentage of marginal ulcer in OHB, and it was 2%. Okay. After that, I went for diverted OHB, Rouen Y, and it's also 2%, the same rate. But we need to say that I keep patients after the operation with PPIs for 1 year, because we know that the longer pouch will produce more acid,
Yeah.
And more acid can induce easily one marginal ulcer. But I noticed also that it was more frequent in men. Why? Because men drink alcohol much more than women here. So people that are smoking or that are still drinking alcohol or that are taking anti-inflammatory non-steroid drugs, those people, I keep them with PPIs without fears in order to avoid any kind of ulceration in the vaginal ulcer. But the big problem is with Roux-en-Y that I've done, and I've told you a lot since 2001. I'm still having patients with marginal ulcers with the Roux-en-Y, in the older Roux-en-Y that are coming to me 10 years later with ulcers. But fortunately, we are able to deal very well with the medical treatment, and we use, of course, the PPIs, the high doses, sucralfate, Helicobacter eradication testing and the eradication, lots of iogurts, probiotics, prebiotics, and I operated all my life just 3 cases of perforation of marginal ulcer, and 2 of them covered, so not in concept of peritonitis.
Sir, excellent. Sir, my question regarding this marginal ulcer. So 2% is also 2%, and that is a figure in a Roux-en-Y gastric bypass, and as well as also in OAGB. Yes, I know in OAGB, due to buffering effect of bile, we face less marginal ulcer, that is acid based, but overall we are facing. So what's my question? So have you any data in these cases who are positive for marginal ulcer with endoscopy? All of them, they were H. pylori positive, one question, or no? And another question, before surgery pre-op, so have you any data? These patients were also H. pylori positive. So now they are, yeah or no? Still you have not such a data. Yes, this patient was also positive before surgery and we eradicate, and now suffering with marginal ulcer. Have you any data?
No, and my answer would say no. Maybe there are some cases, but most of the cases they have ulcer without Helicobacter pylori positive tests. So we are not finding that. Maybe because of the populational habit, because we know that all the doctors in Portugal, they search for Helicobacter and they treat it, they eradicate. All the general practitioners, all the internists, even the cardiologists search for that. So everybody is hunting the Helicobacter. So I suppose the incidence is not so high here. But maybe there is something connected also to the alimentary habits, because what I noticed in Europe very clearly is that the incidence of marginal ulcer is higher in the central and northern countries than in the southern countries. In Spain, Italy, and Greece, the rate of marginal ulcer is generally lower than in the other countries of Europe. Why? Because of the type of food, Mediterranean diet, maybe because of the alcohol consumption, I don't know. But well, because of the oil, but there is a difference indeed. Nobody studied that about, but I am quite sure of that, and I've commented that with many colleagues along my life, and they agree with that.
Sir, for my youngsters, so this is also very important. In these cases that were positive or marginal ulcer positive, so all of them were smokers?
Sorry. That's a good question. 100% are smokers. That's the main issue, the main factor, etiologic factor. No doubts about that. I told you I had 3 cases of perforation, and the more important one was diverted OAGB, so a Roux-en-Y, and he was a smoker, was drinking a lot of alcohol, and he was taking anti-inflammatory non-steroid drugs every day. So he had all the factors, and he was complaining of a painful abdomen for many days. I decided to operate him, and I was thinking honestly in an internal hernia, and what I found was a perforated ulcer with adhesion to the anterior abdominal wall When I opened, it opened largely, and that was the big. But all the patients are smokers, and it's very important
So
to
why
tell to the younger people. That's why I say don't perform bypasses in people that are smoking.
yeah, yeah.
Okay, or they stop the habit, and you can operate on them at least 2 months later, and you have to measure the risk of they can lie to you, they can live for a while, and after the operation they come back to the habit. It happens a lot, but uh, sometimes we cannot do nothing about those guys unless to advise them and to say, I have I'm still in my hospital now, and I found a couple of years ago behind a boy that I operated here with 180 kilos, a big guy, and with OAGP, he's fine. He's about 100 kilos now. He's a tall guy, but he's still smoking. And the other knows, and I said, you need to stop, and he's not able to stop. He's still smoking. So when I found him, I said, I need to kick you.
Sir, why this is the question really. This interview is the main target is this. If you see someone is chain smoker, so just my question, and also someone is using NSAIDs due to osteoarthritis or such a chronic disease, patient need to use NSAIDs. So in such a situation, so can we go for a sleeve gastrectomy?
Yes, I suppose for a sleeve it's not so important. I never heard about ulcerations because of smoking in ulcer, unless a colleague of mine, a very good friend, at one time had a big duodenal bulb ulcer in a sleeve, and the patient was a girl that was smoking, and it was a very difficult case. I suppose that it was in another hospital here in Lisbon, and I suppose at the end it was not good. It was not a good destination, and I suppose that the patient died because of that. But maybe it was a different case of gastrinoma or something like that. But for sure, in a smoker, you can perform a sleeve with no problems.
Yeah.
But not a SASI or an OATB, because there is both.
Not any type of gastric bypass. So we must go for a sleeve, because this is a message from your side to our youngsters, especially be careful. And because these smokers really sometimes they ask, yes, I will not smoke. And if someone is chain smoker, just inform him, yes, in future you will face such a disaster situation. Sir, in your experience, have you faced any intractable marginal ulcer that don't respond to any type of conservative therapy and then need any surgical intervention? And what you did for such a case?
Not really. As I told you, the ones that I have, I could manage it. I only had to go for surgery 3 times. The one I've related to you, I've reported to you just recently. The second one was a woman, the sister of an important chef here in Portugal, but they are from Serbia. They are Serbians. They are very, very anxious people, very anxious, always in stress, always in trouble. Those. And maybe because of that, she had an ulcer. I treated first of all. Later on, she came again, maybe one year later, with another ulcer. I decided, and that was an ugly ulcer in endoscopy. So I decided to go, and there was a perforation of the bowel, not of the anastomosis, but right below the anastomosis. But it was covered, so I could manage easily. But she healed the ulcer again, and she is now with the ulcer. But she was a smoker at the beginning, but she swears she's not smoking anymore. But there are still some acid production because of stress.
Sir, excellent. Sir, yeah. Sir, regarding weight regain after Roux-en-Y gastric bypass, definitely you have now this protocol of longer BP limit. Maybe personally your patients are not facing weight regain, but you are a referral, you are working in a referral center and you are a person. So maybe from another center, if someone consult to with weight regain after Roux-en-Y gastric bypass, what is your surgical protocol? but you prefer distalization. I don't know. What is your protocol?
Well, I suppose nobody can say that doesn't have weight regain. Everybody has cases, even with Roux-en-Y or even with OAGB, even with the duodenal switch, even with the scopinar operation, I had cases of weight regain. So I suppose that there are always non-responders. That is the right word for those situations. There are patients that don't respond to any kind of surgery. Maybe we should not operate them if we could understand that they are non-responders before. Maybe with genetic analysis later on in the future. But about your question, it depends a lot. My first issue is the nutritional pattern. How do the people eat? If they're volume eaters or sweet versus binge eaters. If they're volume eaters, I can consider to go for restriction, to reestablish the restriction. And of course, we can always trim the pouch. That's usually, and I have a lot of cases of that from myself and from other people, and people like Almino Ramos, because of Brazil, we are very connected. I've operated half a dozen of patients now, Almino Ramos, for instance, because they come up to here and they send them to me sometimes with classical Roux-en-Y. But a dilated pouch, we can always trim it. Usually the anastomosis is dilated also, and even the jejunum. Many times there is a large candy cane that is a big pouch where food can be reserved. So I have done a lot of gastrojejunal sleeves in order to trim all together and to put the pouch thin again. And usually when I do that, at least when I was doing that, nowadays it's a little bit different. We can put a ring, not too tight, 6.5 centimeters of diameter is the magical number, just to avoid large bolus, not creating too much ischemia that can induce a perforation of the ring. So trimming with ring is a good solution in my point of view for volume eaters. If the patient is binge or sweet eater, it's different, it won't work. In most cases, I can combine, I can establish some kind of restriction. Sometimes you can do only application of the pouch if you want. But in that case, I distalize the bypass, of course. Distalizing for me is Sugarman type. So I will elongate, I cut the alimentary limb close to the anterior enterostomy, and I put it far in the common limb in order to have a longer bilopancreatic limb. Okay, but again, pay attention to the risk of malnutrition, and that's a situation where the risk is high. So we need to have this to be sure that we have at least 3 meters down for absorption, and the patient is not too old and doesn't have a lot of diarrheas before. I mean, he cannot have a quick bowel transit before, and in that, if so, we need to make it longer, but distalize, but with caution, because it's a tricky operation. And I had at least 2 cases when I distalized it because of weight regain after Roux-en-Y, and in those 2 cases, the patient went through malnutrition after my revision. So I need to revise again, to reoperate again, and make longer the common limb, and the patient were good. But I had to make another operation 2 times because of an inefficient distalization, or too efficient distalization. Nowadays, I have another solution that I learned from friends like Mauricio De Luca and Michael Kramer. Mauricio De Luca is Italian, and Michael Kramer is from Munich. They are very good bariatric and metabolic surgeons, and they are performing an operation with SAGI, S-A-J-I. What is that? Those are easy operations where we perform just an enterostomy, putting the food more ahead, more close to the ileocecal valve, and keeping some transit in the bowel loop in one case. In one case, there is a bowel loop. It's a case of a bowel bypass, if you want. And in the solution for Mauricio De Luca, it cuts the alimentary limb, and there is a 60 centimeters of extruded bowel. Only that's I don't like too much to have extruded bowel. But there is another solution that is not published yet, but will be soon for weight regain after Roux-en-Y. But the classical is restriction, desalization, or both together.
Sir, excellent, sir. Because now one question from Professor Laurent Layani. He's asking, so in such a situation, how long is your common channel?
At least 3 meters. Always the same.
Always 3 meters.
3 meters, yeah. Depending a bit in the profile of the patient, of course, as I explained before.
Sir, so regarding this enterostomy that you are mentioning, so this is a bypass or the small bowel bypass, there is more chance of internal hernia. Are you agree?
Yeah, sure. When I decided to begin with the diverted OAGB, I was saying, oh, I'm winning something, but I'm losing something. That is, I'm losing the safety about internal hernia of OAGB, because again we can have internal hernias. But as I told you before, at least in the 5 years, I'm not having important cases of internal hernia. But that's important to discuss how can we close the spaces. And of course, years before, I was performing a pull string of the space and I closed it. Okay, you understand? And I was counseled later on to do it like a running suture from up to down or down to up. It doesn't matter, because when people, if you analyze after a pull string, after some years, when people lose fat in the meson, there will be a null again. And with the running suture, it doesn't happen so much.
Sir, so much. Sir, and now if we talk about Roux-en-Y, so because you have experienced more than 2 decades, and definitely you face many complications, many side effects of also, and progressively, if as you have mentioned, so you have started your bariatric journey with the gastric bending, then sleeve and Roux-en-Y, and then sleeve, and also OAGB nowadays, and this was the your journey. So how you predict the future of Roux-en-Y? Is it will be a rescue operation in future?
I suppose Roux-en-Y will be still in the field for many years, but a different Roux-en-Y. And what I've told you, I concluded many years ago that the biliopancreatic limb was really the important factor for the weight loss. And I think that nowadays it's a common idea. It's almost consensual, and everybody is doing longer biliopancreatic limbs. Sometimes more ashamed about that, more limited, but other people are doing 2 meters, 2.50 without issues. And there are already different studies, prospective studies, showing that a longer biliopancreatic limbs in the same kind of Roux-en-Y produces a better weight loss and a better anti-diabetic effect. That's a fact. We cannot deny that. So that will be one evolution. And I believe also that people will do longer pouches with time. I can see a lot of surgeons that I discuss with them, and they are doing a lot longer and longer pouches than before, because they understood that it's not very useful to have 3 or 4 centimeters of pouch. Okay, that's almost a total gastrectomy, doesn't matter. And then also that people will understand what I said before, that narrow anastomosis will produce more dilation and more weight regain in the future when the anastomosis will open, because we know that every anastomosis after 2 years will dilate a lot. And if the pouch is bigger, people will hit more and it will be more easy to regain weight. So my issue is, my purview is longer biliopancreatic limbs, longer pouches, and less calibrated anastomosis. But Roux-en-Y will stand the test of the time and it will remain.
Sir, excellent. So your prediction is if Roux-en-Y will be, because as we have learned, Roux-en-Y as a restrictive, okay, there was some hypoabsorption, but the restriction component was dominant. But if Roux-en-Y will go ahead, and if we will be with longer gastric pouch, longer and narrow gastric pouch with the longer BP limb, then maybe someone who are not lover of OAGB, So maybe this surgery will be as a good option for those surgeons. This is your opinion.
Sure. And I know many surgeons that have evoluted in that direction. Uh, Guys like Carlos Vaz in Portugal, Mário Nor in Portugal, Jack Kimpens has done the same evolution, Taquino is doing the same evolution. So a lot of very experienced surgeons are concluded and changing their run-wise in that sense. And it's very important. But about pouch, let me just say one thing. Because when people say a long and slim pouch will produce less restriction, maybe not, because there is the Pole's law that says that a longer tube with a thin caliber reduces 20 or 30 times the speed of food. So those patients will have some restriction, but not based in an anatomical obstruction, based in a functional difficulty of emptying of the pouch. Okay, that's the issue. And of course, very important is to put the food, the nutrients, as Santoro says, bile together with undigested food in the ileum.
Yeah.
We call this the holoileum theory, and that's the most important for the metabolic effect.
Yeah.
Non-digested food together with bile in the ileum. That's our goal.
Yeah. Yeah. So my thanks, sir. Really, it was a great session, definite, and lot of, I think, knowledge and also sharing knowledge. And personally, there is no doubt. Personally, I have learned a lot. Sir, your message for our youngsters who are just now going to start bariatric surgery.
Okay, my message. Let me see my notes because I have some. I suppose that people first of all need to understand that it's a marvelous specialty, very enthusiastic specialty, but we need to study every day. We need to be always evoluting because the story of bariatric surgery is far from being finished. There will be big evolutions in the future for sure, not about surgery, only about endoscopy, about drugs and different modalities of treatment. So we need to be very with a lot of attention on the evolution. Be persistent and be open-minded. Don't sit in your couch about your ideas. Keep your mind open to new ideas, to listen to people, try to understand them in order to get the best of everything that you can hear. If you are a surgeon, try to standardize as much as you can as your procedures. Standardization is the key for the success. If you do it the same way, you are going to be more safe, have less complications. You and all team have also as much as possible the same team, the same assistants, the same anesthesiologists, the same nurses is important in order to get a good outcome with your patients generally. And of course, a good unit with a good multidisciplinary team is essential. We are not heroes. We are just operating people. We want them to modify their lifestyle. That's the last goal. And the operation helps a lot them to do that, but it's not all. People need to be motivated by the psychologists. People need to be educated by the nutritionists to be always changing in the good sense their nutritional habits. Learn to eat better things and to quit from fat and sugar. It's a marathon, not something different. Also important is if you're going for an operation, have the control of the complications. You need to know the complications and be prepared to face them and to solve them. That's very important also for a bariatric surgeon. But be humble if you are not able to do that. Please help assistance from someone that is close to you or available to you in order to assist you and help you to get a better response. Keep a track on your data, register your data, have a database and analyze and publish, because if you are not able to look at your data, you are not learning anything with your patients. And our patients is my idea. My best professors are my patients because they told me what surgeries are doing. You need to be attempt to that situation. last but not least, do what we are doing here, create a networking in order to be able to discuss with many people in the world, learning a lot, as I have done today with Professor Imran, and I suppose we can do in any meeting we attend.
Sir, so much thanks, sir, really. And you are always supportive. And also so much thanks, Professor Lauren Layani. He's live with us and always he's supportive. Sir, he's also he's also asking you, and a special thanks to you, sir. Sir, if you have any other message, then we can close. Have you any message for our viewers?
No, I just hope that this kind of pandemic and now the war can go far away from us and we can meet together in the meetings as we were used to do before. And because more than the science and discussions and the technical issues, it's very good to have friends like you and Layani and other people that can be here. And it's it's a joy. It's precious to have friends all around the world in this specialty, and don't distract about that also.
Sir, so much thanks, and thanks my viewers that always you are with us, and with your support we will continue this series. As you all know, we finished a series of MGB-OAGB. We finished that series that was for 6 months. Then we continue series of safe sleeve gastrectomy. That was also amazing in 6 months. And now this Roux-en-Y gastric bypass is going on every Tuesday, 10 p.m. Dubai time. We are live and with such a legendary bariatric surgeon. Next week, we will be with Professor Bruno Delemon. He will be our guest, and same questions. And we will talk with Bruno and he will share his knowledge. And then again, next week, we will be with Carl Miller, and then we will continue this series till June 2022, and we will have a sum up session. Sir, again, so much thanks. Really, in next series, definite. Because after 6 months, after June, then we will go ahead with metabolic surgeries in low BMI, and 2023 we will continue with redo. Definitely, we need your support, your guidance. So much thanks, sir.
Thank you so much for the invitation. It was a big pleasure to be together with you and all the people that are attending. Thank you so much.
Sir. Have a nice time, sir. Thank you.
Thank you. Bye-bye. Bye-bye. Thanks.